Yes, last but not least, part 4 of our preparation videos. From the large block of liver sonography, we have compiled the information that should enable you to develop a structured examination procedure for the entire 3D organ, the liver. How will we proceed? On one hand, it's about fundamental aspects of the examination technique, then quite simply the right-left problem, which is always widely underestimated. Then we will introduce you to guiding structures, our well-known didactic concept, and help you to recognize them in order to finally bring this together in the form of a checklist for an entire examination procedure. And accompanying this, we will also apply the diagnostic criteria already mentioned in the previous presentations to the liver in terms of size, shape, contour, and internal pattern. Let's begin with the examination technique. First, quite simply, we can mainly use the convex probe, but also especially in the area of the left liver or for assessing the contour, we are happy to use the linear probe. As shown here, the basic idea is to work in the longitudinal and transverse sections for the left liver, the same for the right liver, and very importantly, to use the flank scan for the intercostal areas of the liver. How can this be done? To recall two terms here once again, classically we use fanning, meaning we start from one point and tilt the transducer until we are beyond the organ boundary. For larger areas, as is often the case with the liver, sliding or ironing comes into play, where we have to slide or move the transducer across to capture the entire organ, with the inherent risk that things might be slid over or overlooked during this movement. So fanning is safer in itself, but it won't be sufficient on its own. Regarding positioning, it should be mentioned that while the supine position is naturally used most of the time, here too, since we also have the bile ducts as part of the liver, the oblique left lateral position is definitely helpful and should be used whenever possible. Let's now take another look at the liver in the familiar 2D view, shown here from a ventral perspective with the cranial suspension in the diaphragm area, the falciform ligament, and the junction into the ligamentum teres, which we have already learned is very helpful. We had defined various levels or planes, cranially, naturally, the hepatic veins, venous star, in the middle, the portal plane as a very essential guiding structure, and caudally, in the basement, so to speak, the gallbladder. Viewed from the other side, looking under the liver skirt, so to speak, we had also learned about the ligamentum teres, the portal vein plane, and the gallbladder with its fossa interlobaris as the gallbladder bed. This is roughly how the structures can also be visualized from left to right in an ultrasound. We remember that we had learned about a kind of U-shape or stag's antlers as a useful orientation. And now the question is how to capture this organ in 3D. And for that, it is very important to always fan through from cranial to caudal, meaning to always be conscious of defining the cranial and caudal boundaries. When am I cranial? When I see the hepatic veins. When am I caudal? On the right side, for example, when I have the gallbladder. And our suggestion would be to say, okay, let's work through the whole thing from left to right. There are different ideas about this. Some people start on the right side, but since we start in the upper abdomen with the pancreas and the vessels, we are already over the vessels in the mid-abdomen and effectively have the left liver there as well. So that would be our suggestion. The important thing is just that there is a certain systematic approach in the end, and that it becomes possible to cover all individual sections of the liver, which are then also often divided into segments. So here the left liver up to the ligamentum teres, the left lobe of the liver. Then we have the middle segment, the part between the ligamentum teres and the gallbladder, also called the quadrate lobe or segment 4. Here on the opposite side is our popular caudate lobe, and then the entire right liver, everything to the right of the gallbladder and the vena cava. That means this boundary here, the vena cava gallbladder line, is the actual boundary between the two halves of the liver. Let's just start now with the left liver in a longitudinal section, where we were already active in the area of the vessels and the pancreas anyway. I have shown you the grayscale image here, And if we want to orient ourselves, then everything marked in light green is the entire area of the left liver from the cranial diaphragm boundary to the caudal edge. The cranial diaphragm boundary is not always easy to see with the adjacent heart. Then, directly adjacent caudally, we can see parts of the stomach. Likewise, the pancreas, where we have already learned that the left liver in the inhalation position represents a wonderful acoustic window, is naturally accompanied by the portal vein or the adjacent splenic vein here in this area, and then further dorsally the aorta and the acoustic shadow of the vertebral body. If we now transfer this to a human, we can see here in the left image how I am quite diligently trying to find the transducer position first. So always much higher than you think, high up in the rib cage where I can palpate the whole thing, often difficult to reach in women as well. We place the transducer obliquely in a longitudinal section to then obtain this initial image, vertebral body with acoustic shadowing, aorta, stomach, pancreas, and above that, the left lobe of the liver. And what we notice right away, even though it is actually very clearly visible here, is that we cannot really see the cranial segments well subphrenically, where we have virtually no coupling and no view due to the rib cage. Now we start the video, look at the progression, and we have the patient inhale. The cranial segments come into view. We bring the depth closer and fan out to the left in the body until the liver disappears. On the way back, we have the caudal segments. Here again, the stomach and pancreas are clearly in view. We move back, can look better here, and finally end up at a kind of, yes, white band-like structure, which is what we will be focusing on next. Now I have brought you the ligamentum teres here as one of the important guiding structures in both planes once again. We see the longitudinal section shown on the left, and remembering the ligament we just saw there at the end of the left liver examination, we try to orient ourselves that there is somehow a band-like structure here after all. We have the portal vein again as a wonderful guiding structure. You can imagine it, some also say like a bent thumb, and from this thumb, i.e., from the left portal vein, the ligamentum teres travels towards the abdominal wall. Marked here once again. When we look at the whole thing in cross-section, it is sometimes even easier to visualize. Then we have the pancreas dorsale here, the liver ventrale here, and then if we look very closely, we see this which looks like a small echogenic tumor or a band. This is the ligamentum teres in cross-section. Sometimes it also tends to create an acoustic shadow dorsally, but this is an important landmark for distinguishing where am I in the liver. Up to what point have I been able to examine the liver, and how far was I not able to see yet? So now another pair of images follows, just like in the game memory. We have a longitudinal and a transverse section again. The question is, what do we actually have in front of us here? If we look, then we obviously have the vena cava here in the longitudinal section because it is so nicely compressible. It seems to indent somehow here, and here in the cross section there is liver tissue. What is this about? It is actually about the caudate lobe, which we want to recommend to you as a very deliberate additional guiding structure. Where exactly is it located, and is it actually easier to delineate in the longitudinal section from my perspective? When we look at that, we have the ligamentum venosum as the boundary line between the venous star reaching into the hilum, interestingly enough, often leading exactly to the hepatic artery. So that is the boundary from segment 1 to the rest of the liver. Here in this case, it can also be seen very nicely in the cross section. The problem we have with the demarcation, I've marked it here, is that from my perspective, it's often like a bread roll, so to speak, hovering over the vena cava in the longitudinal section. Quite easy to see when we look at the cross section. I'll go back to the boundary here. Then it is often the case that we might be able to see the area above the vena cava, but it is often difficult to delineate medially. But consciously look into this corner and perceive, have I seen the caudate lobe or not? Now that we have become familiar with the caudate lobe and the ligamentum teres in the still image, we will transfer this to the examination of the left liver in cross-section. We see here in the examiner's position that we place the transducer high up again, press epigastrically under the costal arch, and angle it only to see nothing at first, as can be shown on the right. This means we need help by having the patient take a deep breath in order to slide the liver caudally and fan through it. This means we will hopefully be able to set the venous star cranially and then continue caudally with the portal plane, caudate lobe, ligamentum teres, to be able to fan through the left liver down to the caudal edge. I'll start the video and we'll try to follow the structures. So here we have the venous star cranially, the caudate lobe, the portal plane, and here we can already see the ligamentum teres and the entire cross-section of the left liver. Here again, individually, is the venous star, which always appears so deceptively simple, but unfortunately in reality it is not. One possibility is to scan high epigastrically, angled a bit towards the patient's right and angled towards our left. Then you get a deer-like structure, which allows you to image the venous star, or alternatively right subcostally. In my experience, ideally in the oblique left lateral position. There are very good ways to visualize the venous star. Often you don't see all three veins at once, but it is important to fan through them, to observe the entire course along the veins in order to be able to assess, are they there? Can I see them? Is their path impaired or not? Let's now continue by using the right liver as an example in the cross-sectional examination, and we can already see the examiner's position here, with the transducer placed very obliquely again, subcostally, ramming it under the rib cage, so to speak, in order to then, during deep inspiration, to get the complete view, where the venous star serves as our guiding structure cranially, the portal plane in the middle, and then the gallbladder caudally, and finally the right kidney, which indicates to us that we have left the liver caudally. If I start the video now, we will look at all these guiding structures and also remind ourselves once again which areas we have already seen and which ones we haven't. So we start cranially with the venous star, the portal plane in the middle, and now we have this area here between the gallbladder and the ligamentum teres, which we haven't seen before. I'll start the video again, and of course the liver is to the far right of it. So here is the venous star, the portal plane. We hadn't seen this area before, and of course the entire right liver down to the kidney, which we were missing until now. Now that we have looked at the right and left liver in longitudinal and transverse sections, the last part is the flank scan to look at the intercostal segments. I have brought the grayscale image with me here. We can see that the acoustic coupling is missing at the edges of the image here due to the ribs. But we have a wonderful view. We remember the gallbladder infundibulum was of interest here. Here we have the portal vein, and in this case the cranial parts of the right liver. If we illustrate this with color, we can see the portal vein flowing towards us, parts of the vena cava and the middle hepatic vein. We will take care of the Doppler on day 3. This is only for illustration here. We are practically in the middle of the liver here, in the division of the gallbladder cava line. And if we want to look at liver segments now, it is important to understand that it is about these areas, yes. So this flank section is extremely versatile. However, if I want to examine the liver specifically now, then I look here because I was able to reach these areas from other positions. These areas directly close to the transducer, we will show that in a moment, were very likely not reachable before with the other positioning and breathing maneuvers. So these are the high intercostal subphrenic segments that are at stake, which we need to supplement with this section. Let's also transfer this position into the video display now. Then we have the patient positioning here first, and also the examiner's position. That means the right arm is raised so that the intercostal spaces here are enlarged as much as possible. I have placed the transducer at an angle here in order to catch an intercostal space. And as we can also see here on the right in the image, we have the rib shadows cranially and caudally, or rather on the right and left of the image. But we already have an important starting point here, namely the right kidney and the liver together in the image, in order to be able to evaluate this echo contrast, which can give us indications of liver steatosis. In the following, when I start the video, we will find all the important structures again that we have already learned about with the gallbladder infundibulum, the portal vein, the right hepatic vein, and the right kidney, but we will also clarify which segments of the liver we have not yet looked at. Namely, these are the ones that lie directly under the transducer, i.e. those close to the transducer. These will be the segments here that we have not been able to visualize before. We start the video and now have the right kidney here fanning out. Now there's a block, exactly a little slide. That was the next intercostal space from which I have now fanned medially to the venous star. We try to take another look at the whole thing, and this brief blacking out of the image is in this case the sliding or ironing motion, because I need the next intercostal space to get a full view. So here is the right kidney vena cava portal vein, now it goes black. And here we have the next plane, where we can now also see the cranial segments of the liver up here, which we couldn't see before. So difficult enough, but with that I'm already at the summary. We deliberately wanted to keep it short. We have shown you the key structures. Try to remember these and consciously visualize them. Working with both hands means you have the transducer in your right hand, of course, which you move preferably by tilting and fanning. But you also have your left hand, which has to adjust the depth, because the left lobe of the liver lies much more superficially ventrally than the right lobe, which can go down to 10 or 20 centimeters. Use positioning maneuvers whenever possible, especially the oblique left lateral position and raising the right arm. And with these nice colorful little crosses shown here in mind, we recommend that you come up with your own examination routine that suits you. Whether from left to right, from right to left, the important thing is that you have a routine that fits your clinical daily life and that you also consciously ask yourself, what have I not seen? We recommend doing it from left to right as part of the overall abdominal ultrasound because we start in the middle of the upper abdomen with the pancreas anyway. And as a parting gift, we have put together a checklist for you, which is intended to make it easier for you to clarify for yourself which areas you have seen and which you have not. It looks quite extensive now, but in principle it contains everything we have discussed. Only the assessment of liver size has been omitted here. We will discuss that together on site. But of course, the gallbladder is part of the liver, the hilum, the echocontrast to the right kidney, and very importantly, do not forget the intercostal view. And also for your assessment at the end, was I able to position the patient at all? Yes or no, it also plays a role in how good my examination and accordingly my ability to assess could be. Yes, and with that, I would like to conclude with the goal of future expert training and the hope that we can see each other again on site, both at the simulator and with patients. Until then.